Welcome to the Sharpway Show. So happy to have you with me this evening, a little bit past 7 p.m. on the East Coast. And yes, I am back, and I am back with a very interesting show today. I want to talk about something that affects all of us, and some of us more than others, depending upon what issues we have or how old we are sometimes, even our people in our lives. It is the medical industry. It is doctors and hospitals and physicians and nurse practitioners and all the things that we always complain about and have been complaining about for decades and don't seem to ever fix in any way, shape, or form. And we watch it keep getting worse and worse and worse. And I'm bringing on someone, I should say, who I think really has an insight that many others don't, has a thought process that many others don't, and is going to validate some of the things that I've been saying for years and maybe correct me on certain things that I've been saying for years. I'm very happy to bring aboard. She is a writer, a healer, and an activist, the good Dr. Nikki Johnson. How are you?
I am doing well. Hey, everybody.
Good to see you. And if you want to follow her, you absolutely can. You can follow her on Twitter if you want to at Not a Provider MD on Twitter. Check her out there. And also, I put her some of her other connections on the website. I'm sorry, on our website and such on the YouTube and on the Facebook page. So let me bring up what I think is one of the most important pieces here. And that is the fact that most people out there who are listening do not know of a very big shortage, and that is medical personnel shortage. This is a thing, and it's not a new thing. It's been happening for a while, and no one seems to talk about it. They talk about health insurance, important. They talk about, their pharmaceuticals, important. But we have a problem with literally healthcare professionals. That's true, isn't it?
Absolutely. We're seeing a large exodus from both physicians and nurses, and we are facing astronomical shortages, and we have been at least facing those shortages for a while. But in the last couple of years, we've seen a lot of people leaving the profession, either retiring early, just because they're up there in age and they're just kind of done with everything, or people are transitioning to other fields that are not clinical medicine, but they can still be a doctor and they're doing things kind of behind the scenes, or they're just leaving the profession altogether, which is what I've done. So
yeah, but the thing that gets me is I remember when I was a kid growing up, right? I grew up in the 70s, giving you a little bit of my age, right? I'm born in the 60s, but I really grew up in the 70s. And I remember everybody said, you want to be a doctor, right? You got to be a doctor. And I actually knew of people who had more than one doctor in their family, right? Like the father was a doctor and the son was a doctor, or the mom was a doctor and the son was a nurse. Or so like you could see, or even siblings, right? One's a nurse and one's a doctor, right? You could see it in that regard as I was growing up. But I heard and then noticed afterwards that now that's not a thing. If you're a doctor now, you don't tell your kid to be a doctor. You tell your kid, don't be a doctor. What are you doing? Don't do that. What's changed? Why is that no longer the case?
So I think, oh gosh, this is quite a loaded question. I think though, the general consensus is people who get into the field of medicine, practicing medicine, want to take care of their patients. They want to prevent prevent illness. Encourage people, be like a almost like a life coach, but more of a health coach.
Sure.
And then they want to be there when people are at their most vulnerable and heal, and really take care of people. That's at the heart.
But
I do
our
believe
system
that is
literally
there.
Punishes that. Our system stops that and punishes that.
Yep.
Am I right?
Yes. So I think that the beginning of managed care was really honestly when the downfall began. When we started allowing the corporate side of healthcare to take over the practice of medicine. all the decision making, all the, the money where it changes hands, all of that, all of the algorithms for treating, and the time we spend with our patients. When doctors decided that they didn't want to do that part anymore, they wanted to be employed by these large corporations, or these insurance, or connected with these big managing care organizations, then that's when I believe everything started going downhill.
So, but what I feel, what you just said, right?
To see that it would become what it is right now.
What I see, you tell me if I'm wrong. I live in New York City, and in New York City, we have a two-tiered healthcare system. What I mean by that is, if you are wealthy, you go to private doctors. You don't go to doctors take insurance. You don't do that. You go to private doctors. You swipe your credit card or give them a check. And sometimes, depending upon what good, if you have like a Cadillac insurance program, then they will do some form of reimbursement, right? So you drop, $100 on your doctor, $10 on your doctor. The insurance might throw you 10, $20, whatever they do. They might, or they might not, but you're wealthy, so you don't care. You're going to pay anyway. Yep. If you're not wealthy, you go to someone who takes something like a Medicare, or whatever, Medicaid. It takes something like that plus your insurance. And the level of care is completely different. I mean, it's night and day. I've been to both. It's night and day. I go to a doctor who takes insurance. My appointment's at 2:00. I get seen at 3:45 because they overbook everything. They have to, right? So I get seen an hour. Yes. Yep, that's number one. Number two, the room I'm in, nobody cares about me at all. I'm ignored. It's a crappy room. If there are any magazines, they're 7 years old. Nobody cares. Right?
Right.
There's no water to drink. And when I go to the front to talk to the receptionist, she's far more concerned about did I photocopy the right thing instead of who I am. That's irrelevant, right? I'm filling out paperwork, so that matters. And I fill the same paperwork out every single time. Then when I see my doctor looks at my paperwork, talks to me for maybe 5 minutes, and immediately every single time it ends with one of three things: a prescription, a test, or a procedure. Every time. And because the goal of that doctor, they get paid by those things. So they are incentivized to send me to a test, to get a prescription, or to give me a procedure. That's how they get paid. And they've got to crush everything in. And then I leave and they'll call me later or whatever, but me later. In that scenario, the customer isn't me. The customer is the government or the insurance company. I'm just in the way.
Yeah. Let me correct you here. So
please.
Yes. Part of a lot of the bigger corporations are going to, or have gone to this kind of revenue generated model where a compensated model rather, where doctors get compensated based on the number of the amount of revenue that they bring in. And so some of it is, so doctors will get a base salary, but they'll get a bonus depending on how much revenue they bring in. So for the most part, though, I can tell you that those of us who are working in, those of us who work in large corporate like health centers, like your Mayo clinics, your Cleveland Clinic, those centers, you really want to like basically take care of your patients, but you're not thinking about the reimbursement part, because what you don't realize is we don't know how much revenue we're going to bring the hospital, because we actually don't know. We don't really care like which insurance plan pays out what, because every insurance plan, health plan, your employer sponsored plan, whatever it is going to pay a different amount of reimbursement for you. We don't know that. No one has time to keep track of that. What we do know is we are required to check certain boxes in order for the visit to be complete and for that reimbursement to even get processed. Because there are things that the insurance company won't even consider reimbursing if you did not check off these boxes that said you asked this question, you ordered this test, you did this particular thing, or you made this type of decision, you spent this amount of time with the patient. And so that's in general. I don't think that they're like, I just think most employed physicians just have no idea how the sausage is made. They don't.
Got it.
They don't know where the revenue is coming from. They don't know. I mean, honestly, for me, when I worked in a large health system, I was a medical director for the unit that I worked in, and I actually had to ask the people on the business end to give me the spreadsheet monthly to see, the itemized portions of where the
Right.
revenue was getting generated, because there's a long story that goes
But
back to
hold
that.
on.
But when
You
I
brought up
asked for
though.
that, do you know what the first one of the first questions I was asked was, well, what
What?
are you going to do with this information? Are you sharing this with outside sources? That was the question I was asked.
Oh,
It
got it.
wasn't it wasn't that they don't want us to know because, they want us to know how things get done. They don't want us sharing
Right.
these
They want
contractual
no
agreements and
transparency.
right,
No
exactly.
transparency. Got
So
it. So
if you ask doctors how much this certain test costs, I mean, even just a regular, blood count, most of the physicians in working in a big health system will not know the answer to that unless they own their own independent practice,
right.
where they have to send out to a lab, or they're doing it from their own office. They have no
Mhm.
idea how much it costs.
So, but this is the part I think that a lot of doctors, I think, burns them out, right? Makes them say, I don't want to do this anymore, right? I mean, I don't know what I'm
Yeah.
going to get paid. I don't know how this is going to work. I feel like I'm spending half my time fighting. I know that there's actually an industry of people who basically try to collect money for doctors and hospitals. That's
Yes,
like
there is.
a job. Like
Yeah.
that's your
Yeah.
job. Your job is to
Yep.
fight for money for doctors and hospitals.
Yep.
That
Yes.
seems insane to me, but
Yes.
we're okay with it somehow.
And well, there's also physicians who actually leave their clinical practice and do that particular job. And what they do is they will, either email you or call you and say, "Hey, you forgot to include this in your note," or "I don't see this part in your note. If you add this, or if you change the diagnosis to this, then the reimbursement changes. And,
Yeah.
your note says this. You have the right to bill for this certain thing." So their job is to maximize that. On the other hand, you actually have the insurance companies fighting to not pay things.
Right.
So that position that person is doing, trying to generate that revenue for the hospital or entity, or or the practice, that's necessary because the insurance isn't reimbursing. And you looking at Medicare reimbursement rates, they have dwindled down almost exponentially in the last 20 years, where doctors are barely getting reimbursed for the services that they provide to Medicare recipients. So
So
you
yeah.
gotta make money just to survive in a independent practice. So so you can't you're basically, I mean, honestly, there's lots of things that people are doing that they're almost working for free.
Well, the
With
funny part, you bring this up again. I mean, live in New York City. You have to sometimes struggle to find a doctor who will take Medicare or Medicaid. They're just like,
yes,
I'm not
so
taking it. Like,
yep,
I don't. In fact,
yep.
a lot of them now it's happening, which I think may in the long run be a good thing, but for the short run, it's very painful. Which is a lot of doctors are simply saying, I take no insurance, just none. I will give you a receipt. Good luck. That's all you get.
Yeah.
I take no insurance. I'll give you a receipt. Good luck. I hope your insurance company reimburse you. That's all I'm doing. And I see more and more the better doctors, not better is maybe the wrong. I don't know if they're actually good or not. More famous, more popular doctors, I'll say. They're more popular. They may be better, but the more popular doctors are doing that more and more. Once they get to a point where they
So
think they can do it, I've seen doctors either sell their practices in some way, shape, or form, right? And sometimes they'll work for it, but sell this to some big conglomerate. Or I've seen them go to no insurance. That's been a common that I've seen. Again, that's
yeah.
anecdotal in my area. Is that true across the
So
country?
so that is, I actually don't know the data on how many are doing it at this point, but there's a growing number of independent practices that continue to get bought
Mm,
out by these large corporations, because the smaller practices just can't afford to sustain. They can't keep it open because
right.
of all the government regulations that are required, all of the and then the lack of reimbursement, and
Right.
pediatrics in particular. which is my specialty area, a lot of the patients, at least in Cleveland, Ohio, where I live, the vast majority of them are Medicaid, recipients. So you're really going to be getting like a package deal when it comes to taking care of kids, and in order to keep the lights on and pay people to actually work, that's not necessarily sustainable. So a lot of these practices are opting to get bought out by these large health systems. So you see like your Mayo Clinic's growing, your Cleveland Clinic growing. It's like reaching through across the country, across the world.
Yep.
They have places because they're monopolizing it. You also, then you have, to me, I think the bright side is the people who don't quit, who still want to take care of their patients, will go towards a practice like you named, where they opt out of insurance. And that is, we're going to get to this later, but it's direct primary care.
Yes.
And some people call that concierge medicine, which is a little bit different because concierge medicine tends to be owned by some kind of corporate entity or private equity firm or something like that, where they still hire the health professionals that work with them. And some people don't like that term either, concierge, because it ends up catering to those people who are rich.
It's kind of bougie. It's kind of bougie.
Yeah. So right, exactly, and it ends up catering to those people who are rich, like you experienced, like you explained before. So yes, in general, we do virtually have a two-tiered system. You have people who actually have some employer-sponsored plan, or Medicare or Medicaid. And then you have the people who may have their own health plan, but really they can pay out of pocket for anything, anywhere they go. They don't like it. They don't like an opinion here, or they hear that there's a specialist better for this particular disease, and they want their kid, or themselves to get the best possible care. They're going to fly there and get it, or go there and get it and pay for it. But the people who have a health plan are limited to where they can go, because there's only a select number of providers on the panel that they can actually see. So unless you have any kind of health plan that offers you a flexible savings account or a healthcare savings account, you really are stuck going where the insurance company says. So the direct primary care doctors are primary care doctors, like your family doctors. They tend to be mostly family doctors, family physicians, but there are some internal medicine. There are some specialists are actually doing this too. They're going to a model where they completely opt out of insurance, and they charge a monthly membership fee. So it's like your gym membership
I talk about that all the time.
Yeah. And you pay, anywhere, maybe $50 a month, $90 a month for a family. There's a wide range of where it is. They keep their patient panel limited to a certain number that they can handle, because what they do then is offer you the opportunity to have virtually unlimited access to your doctor. You can
I remember
communicate with text.
That they tried this, that this is what I remember, a story that they tried to make it totally free, but then a lot of elderly people would show up. So they started making a nominal fee, like $5 to show up, or something like that. And then $5 to come up whenever you want. It's $5 or whatever, just so you don't show up for nothing. That was what I heard some people, I forgot what state this was in, but I heard that was happening someplace. Is that kind of thing happening?
It's up to the independent practice. That's the first thing I've heard of. I have a direct primary care physician that I use, and I get unlimited text messages, to her, with her. I can make an appointment, by text message if I need to. She emails me things. We can have a video call if we want, a phone call. We can make an in-office appointment. I can get my labs done outside, and I tend to pay with my healthcare savings account. We do have, my family does have employer sponsored health insurance, but for me, I like to be able to have the time to spend I do not like being controlled. I like to
Yep.
be able to make my own choices. So I like to choose the doctors that I want, people I want to take care of me.
So
And
I
if
want
I
to move
need
down
to
to another
go and
level if
get
I can. No, hold
imaging
on.
or something like that, I want
Yeah.
to go
Let
wherever
me
I can pay the least.
let me touch another piece if I could here. A part that I think drove me crazy. And this goes to the part where the larger organizations, right, like private equity firms, are buying up all of these hospitals and doctors' offices. And I remember hearing that there's some rule, and please correct me if I'm off on this, where doctors can't own a hospital or something, or can't own some. There's some limitation on doctors owning medical practices. Can you help me with
Yeah.
that?
So there's two separate entities. So every state has what they call certificate of need laws,
Oh, yes.
where you actually have to demonstrate a need for a certain type of healthcare facility in
Right.
order for you to actually open up a practice. Before, anybody could just open up a practice. So, but
Yep.
now that you have all of these larger corporations opening up and expanding and taking over all of these smaller, practices, you really, these, the smaller practices are having to compete with that, and it's very difficult to demonstrate a need. So to us, as practicing
Hold on.
physicians,
I
see
have
that
I have
as
something here to think of here. Hold on.
mhm,
I think you could demonstrate it if you just opened it up and nobody came. That would kind of demonstrate there was no need. Or if you open up and people showed up,
correct.
then there was a need. So my
Yes,
view
and
on specific need,
you're out of money, right? Like that's
yes,
you. That's on you.
yes.
So really, what they're doing is basically restricting our right to practice our
Mhm.
craft, and but several states, like I think it's about 35 states that actually have these laws. So that's
New
one
York's
thing,
one of
and
them.
then the second thing is the Affordable Care Act. In the Affordable Care Act that everybody loves so much, um, there's a section in it that eliminated the ability for physicians to own and run hospitals.
I want my audience to hear that.
Yeah.
I've been saying things like this for years, and people think I'm crazy. They think that's not true. That I'm like,
No.
no, no, no. The federal government is so involved in healthcare that if you are a doctor, it is against the law for you to own and run a hospital.
Yep. And the reason that they cite it was it's too much of a conflict of interest, because doctors would then be referring to their friends and
Oh, oh,
taking
oh.
part in, like, deals and contracts with these agents and companies, like, pharma and whatever else, and everybody would just be getting kickbacks and just earning from each other. Well,
Which never happens in private equity firms,
okay, and it
right?
doesn't happen with the government either, right?
Never happens with the
So,
government, never happens with
yeah,
those people, of course.
right. So if you want,
Yes.
um, if people, what people really don't get is what you said, is the government controls pretty much all of healthcare at this point. The
Yes.
major players are the insurance companies. They're sort of like in the center of it all, and then um, they contract with these middlemen to control all the pieces and parts of medicine.
Mm.
So you got you also, like, you have Medicare virtually setting prices on drugs,
Mhm.
setting fees for services for the most part. It's sort of like the standard when it comes to setting prices for things. But then you have the actual um, when it comes to, just say, the people who are worried about the cost of care. A lot of the time, especially seniors, are worried about their cost of their medications, right?
Right, right.
So the the
Well,
the
hold on. As
two
as a as a country,
mhm,
we basically are okay with the doctors going away because we're replacing doctors with pills. So
yes,
we don't care. It's
yep,
like, don't go to a hospital, don't go to a
yep,
doctor, don't just take a
yeah,
pill. Here's a
yes.
pill. Be quiet. Done. That's it. That's all
We're
we're doing.
replacing life choices and things with pills, right? Like
Yeah.
lifestyle decisions and that things that you can do to prevent illness with pills. Okay, you're obese. I mean, like I really was sick recently when I just saw the American Academy of Pediatrics pushing this drug for children with obesity.
Oh, that Ozempic
like
thing, right?
it's not Ozempic. It's actually a different medication that's actually created for children with obesity. It's ridiculous.
So
The
we thought
Ozempic
to
thing, people are
ourselves,
taking that for weight loss themselves, like, and doctors are prescribing that, which I also think is really sick.
so we
Um,
we we said our kids are getting overweight. We could change lifestyle.
yeah,
Nah, we'll give a
right,
pill. We'll get them
right.
right in the pill.
Right. And we're doing this 2 years after we told them to stay home from school. We
Yes.
closed playgrounds and basketball courts and recreation centers and told them to stay home. So
Yes.
what? we recreated the mess
Yes.
with everything
You
else that we're
you
doing to
have brought
kids.
up the piece that I bring up all the time that no one wants to talk about, which is the lockdowns. The lockdowns devastated this country in so many ways, from the increase in crime to medical problems to mental issues, addiction problems, loneliness, obesity. Name the problem.
Yep.
It probably happened because of
Poverty.
2 years locked. Poverty.
Yeah. Poor
Yes.
education. All of it. All of it.
Yes.
Yep.
So bad. And you actually, thank you for bringing that up, because our government just goes, bad things that are happening in 2020. I don't know why. That's what our government keeps telling us. But it's absolute lockdowns.
Right.
Yes.
Right. So go back to like kind of the big costs in healthcare really are mainly your hospitalizations
Mm-hmm.
and your drugs, your pharmaceuticals. The two major players that a lot of people don't really know about that contribute the most money to those costs are your pharmacy benefit managers and your group purchasing organizations. We'll start with one.
Really?
Yes. So the pharmacy benefit
Okay.
managers are companies that are supposed to negotiate prices for your drugs with your insurance company and with your local and with your pharmacy, right? So
Okay.
you go, you get a prescription from your doctor, you take it to the pharmacy.
Right.
They have a price that they can sell it based on what your insurance allows because of an agreement that they made with the pharmacy benefit managers. Overall, this is designed to help save people money. That was like the kind of the original intent to it.
That does not
However,
seem like that's going to work well.
yes, because these contracts are closed off, they're private. No one gets to see what these contracts are. They're different for each insurance company. And right now, there are only a few pharmacy benefit managers that are large corporations now that are mainly calling the shots. You don't have these small business groups that are actually looking out for people, being the leading voices in this. You have large corporations that are allowed to not have their contracts disclosed by, once again, the United States government gave them safe harbor from
But
having.
doctors really shouldn't own hospitals, though. I
Yeah,
mean, I'm glad
yeah,
they put the line
exactly.
there. That
Right,
was
right,
critical.
right. So they negotiate with the
Yes.
pharmaceutical company, your insurer, and your insurer and the local pharmacist. Those are the people who really control the
So
costs
so
of your
hold on one second.
medication
I want
that
to
you
be
get
clear
from
on
the
this.
outpatient.
So what they said was, what we should do is get an elite oligarchy as an extra layer, make it completely opaque and non-transparent, and I'm sure that will lower prices.
Yes, and
Okay, got it.
we need to keep these opaque, no, because we want to be able to negotiate the best deal for you. If we
Oh,
let you know our secret, that we may not be able to get that deal for you.
got it.
That's the
Okay,
argument.
got
But
it.
they
That's
won
it.
that, and
Yeah.
the
Okay.
U.S. government allowed them that safe harbor.
Of
So
course.
that's the excuse me, that's the pharmacy benefit manager. So your like
Wow.
CVS,
Okay.
Express Scripts, CVS Caremark, those are names that everybody might know. Okay. Now, CVS has what? CVS has pharmacies, don't they?
Yes. Lots of
Right?
them. Yes.
Yes, right. And in their pharmacies, they also
There's two in my neighborhood.
they have labs where you can get tests, right?
Hmm.
They have, of course, the medications that are there. They also have what they call these little centers called med hubs or minute clinics where you can actually go
Oh,
and you
right.
can
Yep.
get care, right? By somebody who can then prescribe to you the drugs that are in their pharmacy.
Look at
Okay.
that. How
Any conflict of
coincidence?
interest in any of that at all?
None whatsoever.
No, no. Okay.
No.
All right.
Just let's
So
make
it
sure
gets,
these doctors don't own these hospitals. That's all
yes.
I'm worried about. We got
Mm-hmm.
that down. We're safe.
Okay.
Okay,
Yes.
good.
And
We
then
are now safe.
and a doctor and a CVS can open up a corner store anywhere, right? And then their minute clinic
Yes.
can go there. There's no worry about a certificate of need attached
None.
because it's a retail
Absolutely.
service, right? Okay. All right. So there's that. And then on the inpatient side of things, so you go to the hospital, all of the equipment that you need in the hospital is supplied by different suppliers.
Sure.
Those suppliers are chosen by the hospital in coordination with a group purchasing organization, which is basically another group that contracts and negotiates contracts with the hospital and the supplier of those items that you need to help take care of you, in addition to the medications that you
Hmm.
need to be if you're sick and in the intensive care unit or
Right.
you just had surgery. All of that equipment, all of those medications, all of that stuff gets decided by the group purchasing organization with your hospital. So, and each hospital has one group purchasing organization that they work with.
So hold on to
So,
be clear now. Most of this,
mhm,
a lot of the money coming into these facilities is going to be from Medicare, Medicaid. A lot of that money is coming in from the government. So we are paying for a large chunk of that hospital through our taxpayer dollars. A lot of that hospital is being controlled by lawmakers that we have elected. So with all that in mind, they thought the best thing to do was to have no transparency whatsoever.
correct.
Got it. Okay. Just making
Right?
sure that I was
Right.
clear on that. Okay, good.
Right.
Okay.
It's,
Okay.
and so one of the things that that's been a hot topic is drug shortages,
Yes.
supply shortages,
Hmm.
particularly if you remember in the beginning of the pandemic where we didn't have the PPE, we didn't have the
Yep.
masks, we didn't have the
I
gowns,
remember.
we didn't have the ventilators or things that that ended up not even being what we actually needed to take care of patients with COVID anyway.
Right.
We didn't have those things because why? Because of the negotiated contracts with the group purchasing organizations limited the distribution.
Which
So
is
there
far
are
more important than someone's health. I agree.
absolutely. So there
100%.
are
Yes.
there are three um, group purchasing organizations that cover 80% of drug
Mm.
and device supply to hospitals throughout the United States.
Wow.
Okay,
Wow.
it gets even messier. The contracts that they make, they are also not transparent to either.
Of course.
And so when like all those supplies were short,
Hmm.
the hospital, we can't go out and just say go to Amazon and order some stuff. Okay? Because we've made this deal with this other company. So we can't
So
just do that.
what I'm just curious. What happens if some doctor or some administrator goes, "My God, people are dying, just order and do it." What
They're
happens?
they're they're in violation of this secret contract that none of us have seen.
Ah, so
So
they'll get
what you
fired. They'll
saw,
lose their job.
yeah. So what you saw us do was ration supplies during
Got
the
it.
pandemic.
Okay.
That's why we told people, oh, you can't wear an N95 mask. We're going to reserve those for the hospitals. That's why.
Gotcha.
Okay.
Got
So
it.
go again, government control. And then it gets even
But hold
messier.
on. Is this control though? Is this federal or is this state? Do you know, or is it both?
Well, it's the federal government allows them the safe harbor to keep their
Wow.
contracts secret. Yes.
Wow.
So
wow. The feds
yeah.
are totally in bed with. Wow. Okay. Thank you.
Yeah.
All right.
Yes.
Wow.
Okay. And so the and mind you that that this isn't just limited to kind of to hospitals either, an insurance company. This is also there's group purchasing organizations and PBMs that control the market for Medicare and Medicaid as well. Just so you know this. So these entities are important
Wow.
at every single level
Every
of
level.
government and private
Got
industry.
it.
Yes, yes.
Okay.
So they pretty much control these major costs. And the worst part of it is so on the good news,
Okay. We got some good news. I like
yes,
this. Okay.
exactly.
We
The
got
good
some.
news is the
Okay.
organization that I've been working with for the last at least 5 years is called Free2Care.
Yes, I've seen that. It's free too.
FREE2Care.org. Yep, we published our second report on lowering the cost of healthcare. We published one in 2019. We published another one last year in the fall. And so we've been talking about a lot of these issues for this long. We've been talking about them with Congress. We've been talking about them with our state legislators, and we actually have like ideas that we can use to reform. So some of our ideas Congress has now recently been acting on. So there's been there's been a pharmacy benefit manager transparency bill in the House and one in the Senate. Hopefully they'll merge and come to some agreement and actually come
hold
to a vote.
Hold on. I know there was also some kind of act for like physician residents or something like that act a couple years back to get more doctors.
Yeah,
And
that's a whole nother can of worms.
But my point being,
there have been like 5 or 6 bills.
Here's my point.
Yeah.
Why is that even a thing? And you don't have to answer the question, but I'm just saying in my head, why is that even a thing? Like, if we need more doctors, why does the federal government have to pass a law or an act? If we need more transparency, why do we have to pass a law or it blows my mind that's a thing. And there's no other industry you would do that. Like we need more people to, build, I don't know, we need more people to lay bricks. Let's pass a law to make more bricklayers. We wouldn't do that. There's no way we'd do that, right? That's not a thing.
But the problem is they control the supply of doctors. They control the supply of all these other things with previous laws that they created. That's the problem. So what we're doing, we need to undo bad laws. Is what
So let me ask what I think is a controversial question. If you don't want to answer it, you don't have to. What saying this makes me feel like Medicare for all would be a disaster. But a lot of people want Medicare for all. They say when they talk about Medicare for all, what they say is, no, all this stuff will go away because it'll be Medicare for all. All the bad stuff goes away, they tell me. I don't believe that. Do you have a view on this? If you're too political, you don't get it, I'm okay. But
no,
if you want to say, go ahead.
I have a view on this. I think that
okay.
I think that what people want is simple. They don't want the complex. They want an easy thing. They want not to have to worry about picking an insurance or picking a plan, every year, or if they change employers, where their healthcare benefits are going to come from, if they lose their job, where their people want simple, and they want to know that they actually have something. So that's what people want. But what people don't want are the consequences of such a system.
Ooh,
so
okay. Help me with this.
That's when you actually there's a group, the Job Creators Network, and like a smaller kind of physician group called Physicians for Reform. Back in like late 2019, early 2020, they did market research with over 25,000 people. So it was a huge, like, much better than any kind of surveys. And they asked like people from all demographics. They got great response. Very specific questions about what they wanted in healthcare. And the majority of them said they wanted a Medicare for all. But when you ask them specific questions, do you want short wait times to see a doctor? Do you want to be able to choose the doctor that you want? Do you want to choose where you get your care? Do you want lower costs of your prescription drugs or your hospital stay? Everybody said, of course, yes, right? Well, but what they don't understand is that when you get in Medicare for all, your choices will be limited. Your
Ooh,
your because again, this is another payment plan, which is what it really is.
right.
That's going to give you a list of people who are able to give you the service. The government is going to decide
Mm,
who can be, given this service. So you can get your care here, you can get your care there, and this is how much it's going to cost. There are going to be doctors who are like, okay, fine, we'll do this, just like you saw in Canada and the UK with their NHS system. There are doctors who just kind of went along with it. But then eventually you get to a point where there's those doctors and those services are limited in supply.
okay.
You start to have to wait 3 months, 6 months to see a specialist.
Yeah.
And that leads
That's the VA
all,
system right now.
that's the
That's
VA
the current
system.
VA system. Right. I'm a veteran. That's
Hmm.
the current, an amount
Yep.
of vets I know that they can't sue, but everybody knows they died because they couldn't catch the thing early enough.
Yep.
All the
Yep.
time. Veterans
Yep.
are dying
Yep.
literally every week because they can't get an appointment fast enough to find. By the time they find the problem, it's too late. It's stage 4, or they got
Yep.
heart disease so bad, or liver disease so bad, it's too late. Yep.
Yeah. And the bureaucracy that goes with it, because again, we're dealing with the federal government, there's going to be layers of paperwork that get
Yes.
between you and getting that specialist or the care that you actually want and care that you need. So that
Yes.
increases your wait time as well. And that is a big part of what's happening with the VA too. So
Yes.
you have these people who are between you and the person who's actually taking care of you, making
Yes.
the decisions. That's the problem. It's the people in the middle that slow things down, and that increase the cost. So we're seeing this happen in the UK and Canada.
Yep.
Canadians are coming to America to get specialty care. Even now,
Yep.
they're having longer waits for their primary care and preventive health as well.
Yep.
They also don't have like an ambulance service. Like you and I can call 911 and an ambulance will come, right?
Yep.
They ration the 911 care. Like they will,
Oh,
like,
is that
okay, that
right? I
doesn't
didn't know
sound like
that.
that's an emergency. So yeah. So
So
you
they
have to
decide if
wait.
you got an
You have to
emergency or not.
wait or you take, yeah. Yeah. Um
Okay.
they decide for you. So like
Okay. Well, I
that's
guess it
the
does make
thing.
my
It's
life
like,
easier. They can decide for me. I guess
mhm,
that's nicer, I guess. Wow.
yeah,
So,
yep,
okay, the other thing that I think would happen is the wealthy are never going to put up with that. So
exactly. Yeah, and
they
there it
don't
is again.
care.
So
The
you think
wealthy
we
are
have a
fine.
two-tier system now?
Yes. When I hear wealthy people say we need Medicare for all, what I hear is they really saying we need Medicare for them, not for us. We're still going
Yep.
to our private doctors. We need
Yes,
Medicare for us,
exactly.
not I mean for them,
Yep.
not for us. We're going to go do our own thing still.
Yes, it's like
Okay.
it's like the whole climate agenda too. That they're
Yes.
telling us that we need to do all these things while they go out and fly on their private jets
You
and
why
go
would
to
you
go
be
to
so
their
cruel to
meetings
have
to tell us how
yes.
to live our lives. They don't
Yeah.
see it for them. They don't care who it affects or how it affects them. As
You
long as
you don't deserve to have a plastic straw. I need to have a private jet.
yep,
That's how that works.
yep,
Absolutely.
right,
Yes.
right. Okay,
So let me, if I could, move down to what I think we have might be a good answer at a state level, and you tell me if I'm off here.
okay,
I was saying that if I ran for governor of New York twice, and I was saying that one of my plans, if I had won the governorship, was to make off the bat all certificates of need rubber stamp yes, just yes. That's how, because I can't change the certificate of need laws and rules. I can't change them, right? But I can say that no matter what, it's a yes, basically making them irrelevant. So if you apply, yes, done. Just apply. It's a rubber
hmm
stamp. I don't care, rubber stamp, yes.
yeah.
So I feel like that would help tremendously. Do you think that helps, or is that just a band-aid, doesn't do anything?
I think it definitely will help. I
Okay.
think that especially in places where people are restricted from actually opening up a practice, I think it would definitely open up because,
Okay.
again, like I told you, I have a direct primary care doctor, but my doctor is like almost like 20 miles away.
Right.
So I have to
Right.
drive, and I can do that. I have the luxury to be able to be able to do that. But because
So then
I,
let me go one
I'm,
more step down the road here.
don't need to go to the doctor every day, or every week or
What
every month, like some
what
people
what I,
do.
what I was thinking of doing also is saying something else, which I know would incur lawsuits. Like I'm aware that me making this mandate that I would make would create tons of would create tons of problems. But what if I were to say, as governor, look, medical care is a retail service. And since it's a retail service, you must be as transparent as any other retail service, or I'm going to start fining you. You must be
Yes.
transparent.
So
Now,
here's the other piece of that too. So like a lot of states now, even well, and the federal government, actually under Trump, issued a mandate for hospitals to make their
absolutely.
prices transparent.
Yep.
That the direct primary care practices and these like surgical centers who do this have no problem listing their
Yep.
prices at all. Um, but the
I'm aware
hospital
of that.
and these other big entities have fought against it and then
Yep.
instead chosen to pay fines to the government, because they don't want to show you that what you're getting for your health plan is cheaper than what Bobby over there is getting for his health plan. So yes, so absolutely transparency will be key. Transparency also in your outcomes needs to be
Mm,
available. People need to know that they're not getting, I mean, because yes, we do have people who are like physicians and kind of other health professionals who are opening up all kinds of practices and are doing crappy work. And
sure.
like that's in every field. You're not going to get everybody's not going to be great at it and
Of course.
not good for you. So those
Yep.
things need to be transparent and people need to know what they're getting um, uh, from the service. So that's important. I agree
All
with
right.
you on that.
So let me real fast do a little bit of admin if I could. Guys, if you're watching this show, I'm talking to my audience now, and you're liking it, click that like button.
Nice water.
You have to click the like button. Why? I need to get past Al Gore. Al Gore, yes, algorithms. The algorithms are going to get me. So I need to get past algorithms. So please click that like button. It does matter. If you like it, click the like button. Even if you hate it, click it anyway because I'm good looking. Doesn't matter. I don't care. Click the like button. Doesn't matter. And if you're watching this on Twitter, retweet this right now. Just retweet it so that people can see it. The more you retweet it, the better. If you are on YouTube watching us, you can super chat if you want to at Larry Sharp YouTube. If you want to support the show directly, you may. You like what we're doing? Awesome. Patreon.com/Sharpway. Give me $10 a month so I can keep doing this, spend less time doing my consulting gig during the day. I can do this instead. So please if you can support, please do so. If you want to support me, trying to get a third party in New York State so we can actually do some changes in this damn state, which I need desperately, you can go over to LarrySharp.com/ballot-access. Click that link. Throw me some money so we can get ballot access next year in 2024. But more importantly, the good Dr. Nikki's been good to us, giving us some love, showing us some love. So show her some love in return. Please follow her on Twitter at Not a Provider MD on Twitter, or you can check out some of her other stuff she's doing. The the details in the description on both on YouTube and on Facebook. So I
Yep.
like what you're talking about, but I feel like the big businesses, they already know all of these. Like they know there's a doctor shortage, right? They know there's a healthcare, provider shortage. They get it. And I don't feel like they care that much because I think
They don't.
they're still making money. They're gonna shift from doctor to pill, and they'll just make more pills and they'll make money in the back end. I don't think they care if the doctors get mad, leave, whatever.
Correct.
They care.
Correct. You know what we're seeing, and this is probably this is gonna irritate a lot of people, some people in the audience. So sorry, but what we're seeing and we have seen since the Affordable Care Act came out was a growing number of non-physicians who are getting doctorate degrees and churning out, and diploma mills churning out degrees to allow people to practice. Um, you know, in places where doctors aren't serving. So technically, it was supposed to
Mm.
be the Affordable Care Act was supposed to push states to allow nurse practitioners to be able to practice without, being forced to have some sort of supervision agreement with a physician. Um, and people have their different opinions about whether or not that should be allowed. But from my point of view, that's essentially allowing nurses who have a different form of training than physicians do to practice medicine, basically. But the Affordable Care Act saw that as an option to increase the number of people available to take care of take care of people. Because remember, the Affordable Care Act was basically about giving everybody insurance, right? And
Right.
so they had to have some place for people to go because they already knew we had doctor shortages. So that
But
the
hold on, I have to ask you a
fastest way
simple
to
question.
churn out people to churn out people to take care of people was to churn out nurses because it's a faster process.
Oh, thank you. You answered my question. I was going,
Yeah.
why do
No,
they care?
it's a
They
fast.
care because it's faster to do. So
Yes.
what I'm
And
actually
cheaper.
putting out is and cheaper. So
And
basically what
cheaper.
I'm saying is to fill a gap for the places where there aren't many doctors, particularly like rural areas, we decided let's give the poor people less qualified medical care.
Yes. Now, there's some
That was
people
our
who will
answer.
argue that it is not less qualified care, but in my opinion, it is.
No. It is
It's not
it may
it's not the same care, period, at all.
there are
Like, it
two
is
things I
not
want
the
to bring up
same.
here.
Yeah.
I don't know about the quality. I'm sure there are bad doctors. I didn't say quality care. I said less
Mm-hmm.
qualified care. And it
Yeah.
is without a question less
Yeah.
qualified care. That's
Yeah.
an accurate statement.
Yeah.
And my
Yes.
thing is, if these nurse practitioners, if these physician assistants were the preferred type of medical professional, wouldn't the wealthy people be using them?
Great point, right?
I'm just saying, right?
Great point.
Wealthy
Yes.
people use
Yes.
doctors and
Yeah.
physicians.
Yeah.
And that's why, again, people wonder, why are the wealthy people okay with Medicare for all? Because they're still getting their doctors.
They're going to get.
They're going to give the
Yep.
poor people less qualified medical care and not care.
Yep.
But doesn't that piss a doctor
Right.
off? Doesn't the
And
doctor get pissed off now?
Right. And you already have people concerned about disparities in care. And so some of
Yes.
these same people are the ones who are pushing these as the solution. So it makes no sense at all. None
And
whatsoever.
what they're
So
going to do is go, see, there's still a disparity in care. So what we need is more government regulation.
exactly.
Even
Exactly. And
though
let's
government regulation is what reinforced the difference in care, they will now
Yep.
say, well, now we need more government regulation to make
Yes.
sure. Yes. Okay.
Right. And anytime government proposes a solution to solve a government created crisis, we're in trouble, right?
Yeah. Which means every day. Yes.
Right.
That is
So
absolutely correct.
yeah, so
Yes.
that's kind of where we are, and you have going back to these major entities that are involved in here, your pharmacy benefit managers and your group purchasing
Yes.
organizations. They have come up with these ways to integrate care at every single level, and we call that vertical integration. So you have the insurance company at the top. I mean, you have the pharmacy benefit manager in cahoots with. They have their own specialty pharmacy. So if you know anybody who needs like a biologic drug or certain drugs where they actually have to order it from an online pharmacy and have it shipped to them, some of these groups do that, and then they will have their own group purchasing organization that's, say, maybe in Switzerland somewhere, so that you don't really know about it. So as Congress pushes for more transparency with the pharmacy benefit managers, they're getting clever and hiding with GPOs and having their own GPO and outside of the country. So that brings us to a point where we're basically kind of, again, we're fighting, challenging, the theme of this conversation is that we're challenging government rules to solve problems that government created, right?
Absolutely.
So what we need to do, the answer is, to me, is to get rid of insurance. Just get rid of it, because then you don't need these people negotiating on your behalf. You can
You just
you can
scared
pick,
half of America to death.
well, you can choose it if you want to. Now, granted, I mean, if we want to really get to the point where we're talking about healthy people and creating a healthy society, we need to be focusing on our preventive care, right? And we need
100%.
to be able
Which
to
is almost non-existent.
Yeah, and we need to be able to pick the type of doctor we want. If you want to go see a nurse practitioner, if you want to see a chiropractor, if you want to see a naturopath, that's entirely up to you. As
Yep,
long as you
agreed.
know you have full transparency on how they were trained, what they're
100%.
capable of, and and their outcomes, you go for it. That's for you. If you think those people are the people who are going to keep you healthy, you go for it. But people should be able to have that choice, right?
100%. I agree.
So
Yep.
you're not going to get your choice if we continue on the path we are now, or if we choose Medicare for all. You're not.
All right. So I have
you
another idea.
You can't do that. And if you keep insurance as the primary way you pay for your medical care.
I got to go I'm going to see if I got two separate ideas. You tell me how I'm doing. The first one is, what if we said, if you are a medical practitioner, if you're a doctor, doctor's office, whatever the case may be, and you only service people, you only do service in New York State. That's it. You only service in New York State. You are immune from all federal regulatory bodies because you're not crossing the state line. Why is the federal government involved? You're immune from all federal regulatory bodies.
Well, you still have.
Oh, I think I just did the insurance thing to you. You did the insurance thing to me. Now I just did that to you. I love it. Okay, I shocked you on that one. Okay,
yeah, you got me with that one. I hadn't thought about that. Well, you still have some regulation from the state, and if the state is regulated by the federal government, then the federal government is still going to be regulating you.
Well, what my point being, if I only have to follow state rules, right, and someone wins the governorship or controls the, if you control the governorship, most of the rules made at the state level, particularly New York State, are not laws. Most are not laws, right? There are laws that come from the federal, but state level, most aren't laws. Most of them are recommendations or rules or regulations created by state bodies, right? This board, that board, this thing. The governor runs those.
Yeah.
So the governor can change enforcement on any of those things. In theory, a governor could say, do not, like, for example, certificates of need, right? The government runs that. The governor runs that. In theory, the governor gives everyone out personally. He doesn't, obviously, but in theory, he does.
Yeah.
So the governor can just go no or yes. So what if something like that were to happen, to where I would say, if you're not, as long as you're not, you don't have multiple, as long as you don't have multiple hospitals across state lines, which all the big boys do, the little guys don't. So if you're in one state and you're in, that's all you're in, you're immune from federal regulatory bodies. They have no right to tell you anything. How can they? Take me to court. See it to Supreme Court then, because this is literally the 10th Amendment. I'm not crossing state lines. Why in the world do you have any power over my local doctor's office? Federal government has no power over that. Sorry, no, you don't. Now, I'm saying, we'll create a lawsuit. There's no doubt there will be lawsuits. Of course there will. But my point, the point where I bring some of these up, knowing that I would get heavy pushback and lawsuits from large companies and from, everything else in the world, is that people would hear and know what's happening. And as you know, Dr. Nikki, most people have no idea how bad this is. They are clueless to this.
Correct.
And if we did this, that lawsuit would make the news. And people would be saying, wait, doctors can't own what? That would blow their minds. That's why I was thinking of this type of thing. Tell me if I'm crazy. I'm open to being crazy.
Yeah, well, I'm not sure it's actually necessary. Now that is a piece of kind of like the regulatory piece that I don't really know the answer to. But for direct primary care doctors who are not taking insurance at all, I don't know that some of these regulations apply to them because insurance is out of the picture. So if they're still going to be taking insurance, then I think that's where you're going to get a lawsuit, or especially if they're taking Medicare or Medicaid, that's where you're going to get into the legal battle with something like that. That's my understanding of it. But somebody else who may be able to articulate, that better than me.
Do you think that small doctors' offices would be on board with what I was saying? Do you think they'd be behind me and go, Larry, good idea, let's do it? Or do you think they're like, no, Larry, you're pushing too much. Leave us alone. We're doing fine.
Well,
What's your gut say?
deal. So if I'm in a practice and my patient goes out of town and I need to prescribe something to them or order something for them, how is that going to apply?
Doesn't matter. You're doing
yeah.
business in New York State.
Hmm.
They're your customer in New
Yeah.
York State.
I mean, I don't know. See, that's where the attorneys, all those people need to.
Yeah. Let's be clear.
The regulatory people need to.
This is what they're going to do. I'm not joking, because I know I do some
Yeah.
consulting with criminal defense attorneys, right? And this is what the federal government actually, people who hear this story, it drives them crazy. If I live in Queens. So if you and I are together in Queens, right? Together, you live in Queens, I live in Queens, in this fictitious state, world. And you and I decide we want to do a crime. We're going to go rob a bank in Queens. So I call you on my cell phone and say, hey, Dr. Nikki, let's go rob this bank. And you go, yeah, not a bad idea. We should go do that, right? You agree to go do this thing. That,
you
in
gonna
theory,
call me on the phone to tell me we're going to go rob
yes,
a bank?
I'm not very smart. So I do that.
Clearly.
I'm not very smart. So I do that,
All
right?
Okay.
So as I do that, right, you would think, well, this is a state crime. It's a state bank. This is a state issue. When the cops come, it's going to be local cops are going to pick me up, and they're going to pick us up, for conspiracy to rob a bank, right? Makes sense.
Yep.
No. Right. The feds can grab us if they want to. You know why? Because maybe the cell phone might have bounced off of a tower outside of New York State. Maybe.
Yeah. Or
because
the bank is federally insured. So
they will. Well, that's not the reason why. Because the crimes are all done locally. But because in other words, if I walked up to you and told you and said, hey, you want to rob a bank? The feds couldn't get involved. But once I use a cell phone, now the feds can get involved. So I bring that up because no matter what, the feds are going to sue me and say it's federal. I'm aware I'm going to get sued. I'm aware they're going to say this. But my point is, if I bring this up, will I get doctors behind me, or will they say, Larry, I don't want to go through this. Don't do this. That was my question.
My guess is going to be that most doctors are not going to want to go through it.
That's what I was worried about.
They're not going to want to rock the boat in that way. Now, however, I have some people who are I know some direct primary care doctors who there are some kind of technicalities in how you can use your healthcare savings account.
Okay.
And some of those are being actively fought by direct primary care action groups because they limit the ability for you to pay like a membership fee because you're paying ahead of time for the service rather than paying for the service after the fact or at the time of actual service. So there are some kind of sticky, but there are people who are like, okay, we'll take it. We'll use your HSA as our direct, payment fee, and they just are willing to take that chance because that's how the person chooses to pay. They just let the person know that this is this there's a possibility that you may not be able to pay this way, but we'll take it anyway. So I think like the people who really want to push back and want the freedom of practicing their craft the way they want to and want to minimize the invasion in the exam room between them and their patient, you got a handful of people who are going to be fine with that and like to say bring it on. But for doctors in general, probably not. Especially like 80% of doctors are employed right now, like big corporations. There's not that many in independent care. So that tells you right there.
80%. Oh my God.
It's a breeding issue. It used to be the opposite, like probably
wow.
30 years ago, it was like 20% employed and 80% independent. But it's astronomical.
So here is my worry now. You've just made me worry now by saying that, because I was hoping that there would be enough of a push at the ground level to where we could start moving towards more primary direct care.
I think we're
But
getting
with
there. No, I do think we're getting there, because like my doctor is actually, and her husband are recent graduates. They just say like, we know we're not, we don't want to do this. We know we don't want to work for a corporate entity. We want to have control over our hours. We want to have control over how long we spend with our patients, all of
yeah,
those things.
government's
So
not
when
going to
the
let that happen. Government
getting
is
the
not.
word,
Yeah,
yeah,
government's not going
but
to happen.
getting the word out there is making more people, but we started the show talking about people are leaving the practice of medicine, right?
Yep.
If people who we go through years of training, hundreds
Yes.
of $1,000s in debt,
Yep.
people don't want to. I mean, I walked away from clinical practice a year ago. It's really difficult to walk away from that after you've
Sure.
done that. So people aren't going to don't want to give up that easily. If we can offer them a way where they can actually have some autonomy and really practice the craft that they train for, I think they're going to take it. I do feel hopeful about that.
I hope you're right, because my
Yeah.
worry is all I hear, and I mean on a weekly basis, is Medicare for all, Medicare for all, Medicare for all. I hear that constantly. But I do hear some people
That's because
saying,
that's the loudest voice. Nobody else has a coherent plan that encompasses all the things that you and I have talked here.
yes,
That is like, honestly, some of the think tanks have ideas, but our free to care paper, to me, I'm really proud of that work that we worked on together. Like, you got some brilliant minds on
where do
this
people
report,
find that?
thinking this stuff through. Free2Care.org, FREE, the number two, uh, CARE.org. And then
Here we
when
go.
you get to the website, click on report, and then our paper pulls up. And it actually is a very easy read this time. Our last paper was a lot more kind of technical and legalese, but this one is very kind of like bullet pointed, and uh, I think it would make a great great
Good.
book, for people,
Okay.
if you can just point to it, and like, we really did a good job of trying to make sure people we were speaking in a language that most people would understand.
I like it.
So please,
So
it's a long, it's long. It's like, like 93 pages or something like that. But it just pick a topic and go from there a little bit by a little bit, and we got
so
definitions in there. So all the stuff that I talked about today, the GPOs, the PBMs, that stuff is in there, and some of the legislation that we talked about is in there too. At this point, like, some of that may even be outdated because there's newer laws that have come through
so let me do a
Congress.
couple, if I can, a couple of comments. Joe
Okay.
says, I went through a series of doctor visits 2+ years ago due to an accident. It was amazing how much I felt like I was in a sales store more than I was in a doctor's office.
Hmm.
Everyone wanted
Hmm.
to sell something, prescriptions, procedures. Exactly correct. I think
Yep.
that, yeah,
Yeah.
that's a problem we see all the time.
That's awful. Yeah, and look, I'm a physician, but I'm a patient too. I mean, I have a
Mhm.
chronic illness, so I've experienced this stuff. I understand it. I get it. It sucks. I hate going. I hate going to the doctor for all of those reasons.
Yes, yes.
It's like, I'm here to talk about me. I want to focus on getting healthier, and preventing illness. Can we do that? And can I have some
Right.
time with my doctor? But if I have to have a specialist or something like that, it's like you're going into a factory, right?
Absolutely.
And
Yes.
you're the next part, on
100%.
the conveyor belt.
Yes. Jericho says, if you haven't read the book, The Price We Pay
Oh,
by
yeah.
Dr. Marty Makary, you should.
Yep.
Have you read that book before?
Yes, I have that book. That's a brilliant book.
There we go.
Marty's
Jericho knows what she's talking
Marty's
about.
been a great voice too, speaking out against the COVID stuff. So he's brilliant.
Yes.
He's brilliant.
Um,
That book's awesome.
Gene brings up a very important point. Health insurance is not health care.
Absolutely. I
And
need
I
a
bring this
t-shirt.
up constantly. Yes, your
Yep.
t-shirt. There we go.
Yeah.
Yes.
Yep. It's
Because
not.
when,
It's
go ahead.
not. It's not even insurance at this point, to tell you the truth. We're ended up, like, we pay more in our premiums and our deductibles,
Yes.
than we actually get paid out to us. So, and really, I think, and this is my opinion, I think that people should be paying for their preventive health the same way they pay for the preventive health of everything else, like things that they own. You pay to maintain your car service, right? Why would you care about your body any less than you care about your car or
Because
your
they're going to
home?
have a pill for me, Dr. Nikki.
Yeah.
I'm good. They're going to
Right,
have a
exactly.
pill. We're
So,
fine.
but
Yes.
and it's also some of the cheapest form of care is your preventive care, because it's not
Yes.
reimbursed nearly as much as all of the procedures and the specialty treatments that you get. So if you pay for that and then like have the ability to negotiate or shop and compare between these catastrophic plans where it's actually insurance, so they will
Yes.
pay out in the event you have an emergency or you have some major need. I mean, it's very simplified because we're also not considering the fact that there's lots of people who have chronic illnesses who cannot afford to pay astronomical bills and things like that, where insurance plans basically have made it so that we're all paying into it
Right.
to help
Right.
those benefit those other people. So
Yeah, no,
that
your
is kind
point's
of,
very
but
valid.
they're not gonna like the type of medical care that I'm actually talking about. But if you have to pay to get a lot of the services, a lot of people won't even go
Right.
for certain things. So you're not even guaranteed to get
But
the
that
actual
that is
care
a
that you're
cultural
paying
issue
for.
though, right? There's a
Yeah,
cultural issue in this that's really important. Two cultural pieces. One is I'll touch genes first. People believe when you say, aren't you for healthcare? Don't you people have healthcare? No, I'm talking about healthcare insurance. The two separate things. Of course, some people have healthcare.
yep,
And
yep,
getting better healthcare insurance doesn't mean you're going to get better healthcare. You might,
yeah,
but you also
yeah,
might not. So I think that's
yeah,
piece one. But a second piece you mentioned, if I, to your point, if I have a car, I'm going to pay for the oil change, right? Because I'm trying to make sure my
yep,
car doesn't break down. I'm going
yep,
to pay to get my car washed. I'm going to pay for that stuff, right? But you're
yep,
right. Our culture says I shouldn't pay for a checkup. I shouldn't
yep,
pay for any maintenance on my health. Our culture says we shouldn't pay for that. When maybe that's something that we should pay for and make it to where it's cheap enough to where it's simplified to get checkups. And then
yep,
you only have to about insurance if, okay, I got something bad. I got cancer or I got heart disease or whatever. Okay, now let the insurance kick in. But until that, maybe we shouldn't. I agree with that
yeah,
concept, but I think our culture has said no. Like our culture has said that's not true.
yeah. Our culture has said no, and I think that is the reason why we're in the position that we're in right now, where we're paying for health plans that cover all these things, and maybe you have a copay, maybe you don't have a
Yes.
copay, and you go and you're like, okay, and you walk out of there feeling like you got something for free, but you didn't. And
Right.
when you need a certain test or you need to see a specialist and your insurance isn't giving you the authorization, or you need a medication that needs a prior
Yes.
authorization, they're gatekeeping, and you're not able to actually get the thing that you need, and that's the
Yes.
problem.
I remember I think it was Patty who told me, if I'm not mistaken. She said if you wanted to get if you had a mental health issue and you wanted to get sit with a doctor, you had to wait like 3 months, but they give you a prescription tomorrow. So you're like, I don't want to go on drugs. I want help, right? So I
Yeah,
don't have to go on drugs. Like, well, wait 3 months then.
yeah,
But I'm in trouble now. Okay, here's
hmm,
a drug.
yeah,
And I think that's a common thing we deal with all the time. Jericho says, I worked in refugee health. I think that means nurse practitioner with
hmm,
people who didn't speak English, had socioeconomic issues, and I had 15 minutes to see them no matter what the reason.
yep.
It's an assembly line medicine. Needless to say,
That's a
I left
perfect
family
description.
medicine. So she left. And people
Hmm.
wonder why their providers is always behind. Yeah, there we go.
Yep, exactly.
100%.
And especially when you get into areas like that where people are already underserved, your the amount of health problems increases.
Right.
So
Sure.
those are the people who need you to spend more than 15 minutes with them, more than 20 minutes for a new patient visit. I mean, it's insane.
Absolutely.
The limits and and the people who there was a time period where you go to the doctor and it was an independent practice, and you go there and you sit there and you wait for an hour for that doctor, you know what, and you didn't mind waiting because that doctor was going to spend a lot of time with you,
Right.
and give you that personalized care that you deserve. And not saying you should have to wait, that long. I don't have to wait that long with my doctor. My appointment is my appointment. That is my time with my doctor. They don't go over.
Yep.
They, that's the benefit of direct primary care too, is they limit the amount of patients on their panel. So
Right.
they have that time for you. But that is it. It has become assembly line medicine. They tell us these are how many patients you have to see in this
Yep.
time block. And you also have someone else doing your schedule. I'll tell you, tell
Right.
you that too. So for the people who especially are working in private care and like these big corporations or these big, otherwise, like even if it's a government sponsored entity, like they still have someone else controlling your schedule, and they're allotted a certain amount of times. It's all computerized anyway. So
Right.
it's like you have to put this patient in this time slot, a new patient in this slot, an urgent visit in this slot, and that kind of thing. And they will fill it as much as they can. Some of the practices built in like the no-show rate for your particular practice. And so they will double book times that are more likely to be,
Yes.
have a no-show, or a patient who is more likely to be a no-show. They'll double book. So you're waiting for
Yep.
that too.
Absolutely. Every single time. It's crazy. So let me talk to my audience for a second. Guys, if you like what you hear, and do me a favor, click that like button. It does matter, right? Please do so. If you're watching this on Twitter, please retweet this I got to get past these algorithms. I got to get past them. So you got to help me out and make that happen, please. And also, good Dr. Nikki's given us some time. She's given us some love. So show her some love. Follow her on Not a Provider MD, or head on over to the description that I put on either YouTube or Facebook. See what she's doing and follow her. Check her out there. Is there anything we missed? Something we should be talking about before we wrap this up?
No, not really. I mean, there's a lot.
No? Someone loves you.
There's a lot to this. I mean, I can pause.
You have a fan.
Hi,
Yes.
Abdullah.
Yes. So yes.
I love you back.
There we go. So,
Yeah.
well, I want to say I appreciate the time you gave us. Very insightful. I hope you'll choose to come back one day. Maybe when we have some better news.
Yeah,
I hope that's true.
Yes, right. Let's talk. I like solutions. So
I love that. That's
let's
awesome.
talk those. Let's fix this mess that we're in. But yeah,
That's what I'm
Medicare
talking
for all
about.
is not it, and what we're doing right now is not it. So
that's correct. Excellent. Thanks so much for your time. Everybody else, thank you so much for watching. I will be back not tomorrow. Tomorrow I'm doing a separate segment on, believe it or not, a news channel, which I will release on Friday. But I will be back on Friday for 2 shows at 3 p.m. and again at 7 p.m. And then, of course, Monday at 9 p.m. I will see you all